Hello, and thank you for taking the time to view this presentation. I'm Leah Kulp, a PhD student at Drexel University, and this work was done in collaboration with doctors and medical experts at Children's National Medical Center in Washington, D.C. The goal of this work is to understand factors contributing to checklist non-compliance and how we can better design systems to support compliant use within the context of trauma resuscitation. So the motivation for this work. In terms of checklist compliance, this can be defined in many ways. Compliance could mean adhering to protocols and making sure that all tasks are performed by the team. Compliance could also mean compliance with the checklist and making sure that all of the boxes are checked off. And studies have measured this in different ways. Some studies have found that checklists do increase compliance with protocols, meaning more tasks are performed with the presence of a checklist. However, other studies have found that checklist compliance does not always correlate with task performance. So one study found that 84% of items were checked, but only 54% of the tasks were actually completed. In studies of documentation and timeliness, such as on electronic health records, EHRs, introduction of these systems has helped support collaboration and communication. But again, we see misalignments between the design of these systems and actual practice, leading to workarounds and delayed performance. So one study found only 8% of tasks were performed in real time, and most of these tasks were actually delayed. Non-compliant checklist use in these settings may provide false reassurance that tasks have been performed or that tasks haven't been performed when they actually have, posing widespread risks to safety. So what can we do about it? We need to first understand the factors that contribute to non-compliant use and then design features to better support dynamic work processes. So trauma resuscitation is a high-risk, time-critical process of treating patients with acute injuries that require medical attention. So the goal is to stabilize the patient, identify any life-threatening injuries, and develop a plan for patient hospitalization. This process requires teamwork and is guided by a standard process called ATLS, Advanced Trauma Life Support. This includes two sections: the primary survey of the ABCDEs to quickly assess major physiological systems, and then the secondary survey, which is a head-to-toe physical exam of any other injuries. When a trauma patient comes into the hospital, a team of 7 to 15 members assembles to take care of the patient and have different roles and responsibilities. One of the roles is the team leader. This is a hands-off role, someone who stands at the foot of the bed and guides the team to perform all tasks and helps come up with the care plan at the end. To support compliance with this ATLS protocol, we created a paper checklist in 2012 with all of the steps on the ATLS protocol. In 2017, we introduced a digital checklist, as you can see on the right. Team leaders have been using this for the past 3 years. Our overall research question in this study is, what factors contribute to compliance and timeliness of checklist interactions? To do this, we first started by reviewing videos and generating activity logs. We watched videos of actual cases and marked the start and end times of every single activity that was happening. We also matched checklist items with tasks in these activity logs. We also gathered contextual information that is stored in a hospital database that includes information about the patients. To analyze the data, we first wanted to determine checklist compliance. So we looked at the activity logs to determine whether tasks were started and performed all the way to completion, started but not actually completed based on our data dictionary, or just not performed at all. And then we compared these to the checklist to see if the item was checked or not checked when these different task performance were occurring. We also compared timestamps between the activity logs and the checklist logs to determine the timeliness of these checklist interactions. To take it a step further with the timing of the checkoffs, we also compared this to the contextual information that we had. And finally, we conducted qualitative video review to provide a deeper understanding of what's actually happening when non-compliant behaviors are occurring. So first, we found 5 checklist compliant behaviors. So first, I want to talk about the compliant behaviors. So this is what we would like to achieve: 100% compliance would be a true check, which is when the task is performed and the item is checked off. So we found that 79% of all checked off items were true checks. Most commonly, these were secondary survey exam items, that head-to-toe physical exam, and primary survey items. We found that the true non-checks, so this is when the task is not performed and the item is not checked, again, a compliant behavior, 4% of these were true non-checks. And this actually occurred on the pre-arrival items and the primary survey items. For the non-compliant behaviors, we found 3 different types of behaviors. First, we're going to talk about false checks. This is when the task is not performed, but then the item is checked off. We found that this happened for 16% of all checked items. And the most common ones were ocular integrity, which is an evaluation of the eyes on the secondary survey, confirming that the patient has an IV placed, and the nose exam on the secondary survey. From the video review, we have some qualitative observations. So first, we found that those secondary survey items are often grouped with other exams. For example, when the provider is checking the face, they might not necessarily look at eyes, nose, mouth individually. They might just say, the facial bones are clear, no injuries on the face. Secondly, some of the tasks are being done pre-hospital. So for the IV access, sometimes the patient comes in with an IV, and so this box is checked off by the leader, but this is actually not coded because it's not performed in the trauma room. The second non-compliant behavior that we found were inaccurate checks. So this means that the task was started but not performed all the way to completion, and then the corresponding item was checked off. 5% of all checked items were inaccurate checks. The most common ones were checking the pulses, which requires checking pulses on 4 different sides of the body. And then again on the secondary survey, the mouth exam and the nose exam. From our video review, we found that the pulses might not be completed because this requires checking all 4 pulse areas. And if another provider is trying to get IV access or check the blood pressure on one of the arms, the bedside provider might just skip checking the pulse on the upper extremity. Secondly, we found that the secondary survey exams tasks might be performed but not verbalized. Finally, for non-compliant behaviors, we found that there were failed checks. So this one is different. This is when the task is performed, but the item is actually not checked off. This was 7% of all possible checks were failed checks. The most common ones were for checking the patient's temperature on the primary survey and making sure that the oxygen mask was connected and giving fluid or blood. Our qualitative observations showed that leaders missed verbalization of temperature due to the noisy environment. So when we went back and checked the videos, we often found that the provider or one of the nurses was reporting the temperature, but there's a lot going on, and the leader with the checklist just missed this exam. Second, the giving fluid and blood does not apply to all patients. And finally, the pre-arrival items. So this means that when the team leader arrives to the room after the patient, maybe even once the team has started the primary survey, they'll have missed all of the pre-arrival tasks. So even though these tasks were completed, the leader might not check off these items because they weren't in the room when they were done. Next, I'm going to talk about how the timing of checkoffs related to the task performance. So this was the comparison of timestamps between activity logs and checklist logs. First, we categorized all of the true checks as checked before the task started, during task performance, or after the task was completed. We found that 15% of all of these checkoffs were pre-checks. So this occurred before the task even started. The most common ones were the heart rate, the back exam, and the warm blanket placement. So we noticed that these tasks were tasks that were long duration, so they might take a little bit longer, or multi-step tasks. Secondly, we looked at checkoffs that occurred during task performance. So these we called real-time checks, and this was 16% of all true checks. The most common ones were the C-spine exam, the back exam, and confirming that oxygen mask was placed on the patient. Again, our qualitative observation was that these were long duration tasks, so it's easier to check off during task performance. Finally, we looked at tasks that were checked after task performance. We called these post checks. 69% of these were post checks, and this is what we would expect, right? The task is performed, and then the leader diligently checks the box off. Some of the observations were that the vitals actually show up on a monitor once the sensors are connected to the patient, and so the leader can just quickly check these off. And we also found that the pre-arrival items checked after the leader arrives. So some of these tasks are done, and then when the leader arrives, they're checking these off. So it's checking off after these tasks were performed. We found that 2 minutes or longer was our threshold for a delay. So task is performed, 2 minutes later, team leader is checking the box off. And the items with the longest delays were mostly pre-arrival items. As I mentioned, these tasks might be done before the leader even arrives to the room. And then the vitals, and finally, warm blanket placement. And while these delays might not seem like a long time, only 2 minutes, they could lead to negative outcomes in concurrent checklist use. So next I'm going to talk about the association between those delayed checkoffs and then the context attributes. And the context that we found were associated with delayed checkoffs included the team leader's late arrival. We also found that overall, every section and then the secondary survey items were affected by patients with penetrating injuries. Secondary survey items were affected by attending level activations. So this means the highest level acuity patient, there might be more providers in the room, tasks are more delayed, and item checkoffs are delayed. I want to quickly discuss the factors contributing to non-compliant use, and then how we can reconsider checklist design to better support these contexts. So first, the work practices and task perceptions have formed at the bedside over time may not be the same as our coding dictionary. So the actual order of items or tasks that are performed really varies based on patient status, the team members that are in the room, and other emerging context information. Teams might not always follow the prescribed order of tasks, especially if there's an intervention, they have to place a chest tube or intubate the patient. And these activities are running continuously. They stop and resume and overlap, so it might be hard for the team leader to accurately mark when tasks are occurring based on a simple checklist. And then second, the variable nature of task length and complexity really contributes to checklist compliance. So as we saw, tasks with longer duration or multiple steps were affecting non-compliant behaviors. So now, how can we reconsider checklist design to support these different types of tasks? First, I'll talk about supporting different types of task performance. In the interest of time, I'm only going to talk about a few of these. So first, we found that tasks with long durations affected checklist compliance. So design solution could be to indicate when the task is started, and then later, once the task is completed, indicating that completion. This way, the team leader can more accurately document the task performance. Second, tasks that are performed more than once. So we did find that the vitals are being reported multiple times, and this feature would automatically pull from the vitals monitor and allow the leader to record multiple vital sign values. So now supporting retrospective checking. So these are often tasks that are performed before the patient arrives or before the leader arrives. As we mentioned, when the leader arrives late, the team has already performed lots of tasks, and then they show up and are checking things off, and they might be checked off delayed, or they might not be checked off at all. So how can we better support this? The first option is a section for tasks performed before the main event. So this would be a pre-hospital form. On the right is an example of what this might look like. Instead of having the leader write these notes in, giving a structured form would help streamline this data entry, and also allowing other providers in the room to fill this out before the leader arrives so that the documentation is more accurate to the task performance. So providing a way for leaders to indicate whether tasks were performed pre-hospital would allow them to more accurately document what's going on. We found that the vitals and the pre-arrival items are checked off 2 minutes after task completion. And from the video review, we found that some leaders just checked items off at the end of the case instead of checking each item off after the task was performed. One way we can better support this is to show values that were previously entered. So with this pre-hospital form, we can then show these values later when the team leader gets to tasks that are relevant. Second, we can have a timer showing the elapsed time since the first checkoff, and this would help leaders conceptualize how much time since the patient has arrived in the room. And finally, showing timestamps for individual checklist items would also provide a better idea of the progress of the resuscitation for the leader. So in conclusion, we are understanding factors that contribute to compliance and timeliness of checklist interactions. And from these findings, such as false checks, inaccurate checks, and failed checks of non-compliant behaviors, we can then reconsider checklist design, how to better support these non-compliant behaviors to try to achieve 100% compliance with the checklist. I'd like to thank my collaborators at Drexel University, Children's National Medical Center, and the funding bodies that have made this research possible. If you have any questions, feel free to email me, ljk58@drexel.edu, and I'd be happy to talk about it. Thank you.